Hello, everyone. Uh, Welcome to another Health for the World Grand Round presentation. Today, we're going to be having a presentation by Dr. Shabnam A. Fidvi. She's a medical director at the Advanced Imaging at Montefiore Medical Park, New York. And also, she's an associate professor from the Department of Radiology at the Albert Einstein College of Medicine. And she's also a Health for the World Montefiore chapter, just as from us Tanzania group, and I believe from others across the world. Yeah, and we are going to have a presentation about imaging of adnexal masses. Welcome, Dr. Shabnam.
Thank you so much, Dr. Malu.
Yeah.
It's a pleasure for me to be speaking to everyone, particularly in Tanzania from New York today. And I really love teaching, so it's an honor for me to talk today about imaging of adnexal masses. I have a lot of ground to cover, so I'll get started right away. I have no conflicts of interest. The basic learning objectives of this presentation are to review the imaging characteristics of common non-neoplastic ovarian and tubal pathology, to review the categories of ovarian neoplasms, and then finally to identify ovarian neoplasms on the basis of their imaging appearances. In terms of benign entities that I'll be talking about, in the ovaries, I'll be discussing functional cysts, namely follicular cysts and corpus luteal cysts. I'll talk about ovarian hyperstimulation syndrome and theca-Luton cysts, adnexal torsion, and polycystic ovarian syndrome. I will not be talking about endometrioma because I believe this has been discussed previously in depth by one of my colleagues. In the adnexa, I'll be talking about tubal pathology, namely hydrosalpinx and pelvic inflammatory disease, and also cover paraovarian cysts and peritoneal inclusion cysts. It's really important when we interpret pelvic imaging that we know patient's clinical history, and the factors that we want to know about are the age of the patient, the clinical symptoms like fever, vaginal discharge, and pain. This is particularly important in the setting of pelvic inflammatory disease. We also want to know the patient's menstrual cycle and her time in the cycle, pregnancy status, whether she's receiving any drug therapy, including hormone replacement therapy, and ovulation stimulation drugs like clomiphene citrate, and then also any previous surgical and medical history, including any history of cancer. I do want to touch briefly on ORADS, which is the Ovarian Reporting and Data System. There's an ORADS ultrasound version as well as an ORADS MRI version. The latest update was in 2022 by the ACR. And actually, a comprehensive review of ORADS is beyond the scope of this lecture. And full disclosure, we don't use ORADS in our practice, but it might be something that you want to learn more about. So with my slides, I've included resource information that you can feel free to visit in your own time should you want to. But basically, ORADS is a standardized lexicon which uses descriptors for adnexal lesions. They evaluate things like the wall of the lesion, if there's any mural irregularity, septae within the lesion, internal echoes within the lesion, internal vascularity. Those are all features on ultrasound, obviously. And then based on those features, it assigns adnexal lesions a scoring system. The scoring system runs from 0 to 5, and then it provides management recommendations based on the findings. So again, this is a terrific resource from Radiology 2023 for ORADS ultrasound version 2022. And I'll briefly run through the different ORAD scores so then you can get a flavor of it. ORAD score 1 is basically 0% risk of malignancy and a normal ovary. Either you'll see no ovarian lesion, or you can see a follicular cyst or a corpus luteal cyst. And this applies only in premenopausal patients. ORADS 2 lesions are almost certainly benign, so they have less than a 1% risk of malignancy. This category includes simple cysts, which are more than 3 centimeters, but less than 10 centimeters. It also includes unilocular cysts and bilocular cysts, less than 10 centimeters, and then typical benign lesions, which I'll be showing you later in the lecture. Those include things like hemorrhagic cysts, endometriomas, dermoid cysts, and then tubal entities like hydrosalpinx, paravariant cysts, and peritoneal inclusion cysts. ORADS score 3 lesions are basically low-risk lesions. They carry a 1 to less than 10% risk of malignancy. As you go higher, ORADS score 4 lesions are intermediate risk lesions with a 10 to less than 50% risk of malignancy. You will see that these lesions are increasing in internal complexity. And then the final category is ORADS 5, which is a high-risk lesion with a greater than or equal to 50% risk of malignancy. When I review ovarian neoplasms in the latter half of this presentation, you'll notice that most of those lesions are either going to be ORADS 4 or ORADS 5. So let's start with ORAD score 1, which is basically functional ovarian cysts. And these include follicular cysts and corpus luteal cysts. In a menstruating female, they're very common during a normal ovarian cycle, which is shown by the schematic here. Now, a follicular cyst occurs when a mature follicle fails to rupture or regress. After ovulation, corpus luteal cyst typically regresses. If the patient gets pregnant, then it'll continue as the corpus luteum of pregnancy up until 16 weeks, after which the placenta takes over the function of pregnancy. So just a brief recap of ORAD score 1 again. This includes follicular cysts and corpus luteal cysts in premenopausal patients. And let's go on to the imaging features. So what does a follicular cyst look like? This is usually a 3 to 8 centimeter cyst, and it's a simple unilocular cyst. Here on this transvaginal ultrasound image, you see a follicular cyst, which meets all criteria for a simple cyst on ultrasound, in that it's anechoic, it has a thin, imperceptible wall, you have posterior acoustic enhancement, and if you were to put color on this lesion, you would see no internal vascularity within it. How about on CT? This non-contrast axial CT through the pelvis shows a follicular cyst within the left adnexal. If you were to put a density value on this, this would basically be equal to water density, meaning that it's simple fluid. On this axial T2 weighted MR image, again, you can see a follicular cyst, which is basically homogeneously T2 hyperintense, and there's a tiny amount of ascites anterior to it. This is the uterus posterior to the follicular cyst. How does a corpus luteal cyst differ? So this is also a unilocular cyst, but unlike a follicular cyst, it actually has a thick wall, and the wall is typically echogenic. Now, it may or may not have internal echoes, like in these examples here. It may or may not have crenulated margins, which basically means wavy margins, like in this example. But when you put color flow Doppler on, these lesions will show peripheral low resistance flow, like in all the examples on these ultrasound images. Now, this is sometimes called the ring of fire. It's not to be confused with the ring of fire that's used in the adnexal and the setting of an ectopic pregnancy. Remember that ovarian ectopic pregnancies are really, really uncommon. So if you see a ring of fire in the ovary, it's more likely than not to be a corpus luteal cyst. Occasionally, corpus luteal cysts may have a more solid appearance, like this example here. It's heterogeneously hypoechoic, but on color Doppler, there's peripheral vascularity, but no internal vascularity, and this is consistent with a hemorrhagic corpus luteal cyst. How about in cross-sectional imaging? Here's a contrast-enhanced axial CT through the pelvis showing the uterus. Within the right ovary, you can see a rim-enhancing lesion, which is typical for a corpus luteal cyst. On an axial T2 weighted image, this lesion appears heterogeneously T2 hyperintense. And then on a axial post-contrast fat-suppressed image, you see rim enhancement like on CT. And again, these are all features of a corpus luteal cyst, which typically regresses by the 16th week of pregnancy when the placenta takes over. Now, both follicular cysts and corpus luteal cysts can rupture, and they can be a potential source of pain in the patient, like in these examples shown here. So this is a transabdominal pelvic ultrasound. Here's the urinary bladder, here's the uterus, and the orange arrow is showing some complex mixed echogenicity material within the pelvis. There was no color Doppler within this area. A subsequent transvaginal ultrasound, you can see a little bit of the ovary with some tiny follicles, but there's a lot of mixed echogenicity avascular material next to the ovary, suggesting blood products. So in both of these patients, there's probably a pelvic hemoperitoneum. On these axial and coronal contrast-enhanced CT images, you see that there's a large follicle within the left ovary. Here's the uterus. And you'll also notice that there's high-density material within the anterior pelvis. If you were to put density values on, this would be higher than the simple fluid in the follicular cyst. And this is likely, again, blood products and a pelvic hemoperitoneum. You might also notice that this area actually is higher in density compared to the right lower quadrant fluid. And this is actually a blood clot. So this is called the sentinel sign. And what it basically indicates is that the source of bleeding is likely from the pelvis. Moving on to ORADS score 2 lesions now. So these are almost certainly benign lesions. Again, the risk of malignancy is less than 1%. Now, this category includes simple cysts from 3 to 10 centimeters. It also includes unilocular and bilocular cysts from 3 to 10 centimeters. And like I alluded to before, there's certain classic benign lesions within this category, which include hemorrhagic cyst, dermoid cyst, endometrioma, which I will not be discussing, paraovarian cyst, peritoneal inclusion cyst, and hydrosalpinx, the last 3 being in the adnexal. A brief recap of ORADS 2 classic benign lesions, and here's the resource for you to look it up should you choose to do so. And this is the management recommendations. I'll just briefly review the management recommendations for ORADS category 2 lesions. So these are almost certainly benign again. If you see a simple cyst, between 3 to 5 centimeters. If the patient is premenopausal, it requires no follow-up. In a postmenopausal patient, less than or 3 centimeters, no follow-up. But in postmenopausal patients, lesions between 3 to 5 centimeters, you want to follow up with ultrasound in 12 months. In simple cysts, more than 5 centimeters, but less than 10 centimeters in both pre and postmenopausal patients, you want to get a follow-up ultrasound in 12 months. Now, in terms of unilocular and bilocular cysts, unilocular cysts have an incomplete septation. Bilocular cysts will have one complete septation. Both of these lesions can have internal echoes. If they're less than or equal to 3 centimeters, no follow-up in premenopausal patient. In a postmenopausal patient, you'll follow up with ultrasound in 12 months. If these lesions are greater than 3 but less than 10 centimeters, in both pre and postmenopausal patients, you follow up in 6 months. And then the classic benign lesions have their own management recommendations, which I showed on the previous slide. So let's look at the ultrasound features first of a hemorrhagic cyst. Again, it's a unilocular cyst. It has no internal vascularity. And to qualify as a hemorrhagic cyst, it has to show at least one of the following patterns on ultrasound. So it can have a reticular pattern, which is basically fine, thin intersecting lines, like on this example. And these are basically fibrin strands. This appearance on ultrasound is described as a fishnet or a lacy pattern. If it doesn't have this appearance, it can also show rectata clot, like in these 2 examples here. So basically, there'll be an intracystic component with either straight margins, like in this example here, or it can have either concave or angular margins, like in this example below. In either event, none of these lesions will demonstrate internal vascularity. How about an MRI? Now, like everywhere else in the body, the signal characteristics basically vary depending on the age of hemorrhage. It's important to remember that the way hemorrhage evolves is that the center of the lesion has more chronic blood products, while the periphery of the lesion has more subacute blood products. So this is an example of what a hemorrhagic cyst looks like on MRI. On this axial fat-sat image, you can see that the lesion is T1 hyperintense, indicating blood. On this axial T2 weighted image, you'll see that the lesion actually has a fluid hematocrit level, with the star showing the hematocrit level. It also has some internal T2 hypointense kind of squiggly material, which corresponds with the fibrin strands that I showed you earlier on ultrasound. And on axial post-contrast fat-sat images, the lesion shows no internal enhancement, so it fulfills all the criteria for a hemorrhagic cyst. Endometriomas typically show T2 shading, as was presented to you previously. The next entity that I'll talk about is theca lutein cysts. Now, these are associated with really high beta-HCG levels, and they're typically seen in two scenarios. The first is gestational trophoblastic disease, and then the second is ovarian hyperstimulation syndrome. And these patients may also present with abdominal pain and distension, nausea, and vomiting. Now, in this transabdominal ultrasound image, you can see that the endometrium is thickened within the uterus. And when you look at the ovaries, this is the right ovary, this is the left ovary, both of them are pretty large. So the maximal dimension for the right ovary is 7.4 centimeters, same for the left ovary. You'll see that both ovaries contain multiple large cysts, and the patient also has some pelvic ascites. So this was a patient with ovarian hyperstimulation syndrome who actually had received clomiphene citrate. What about CT? What did they look like? So again, bilateral enlarged ovaries, both containing multiple large cysts. They can bleed, rupture, or even predispose the ovaries to torsion. And because of the clinical scenario, you can see ascites, pleural effusion, hemorrhage, and DIC. So this axial contrast enhanced CT image shows both ovaries to be pretty enlarged, and they contain multiple bilateral cysts. The patient also has ascites. And on the image lower down, again, you can see bilaterally enlarged ovaries, this one on the right, this one on the left. This happens to be the uterus, and this is a small amount of pelvic ascites. Again, this is a patient with ovarian hyperstimulation syndrome. The next entity I'll discuss is ovarian or adnexal torsion. I put in the schematic of a whirlpool to remind you to always evaluate the adnexal vasculature and suspected cases of torsion. So ovarian or adnexal torsion accounts for about 3% of gynecological emergencies. It usually occurs in premenopausal patients. Now, about 20% of pregnant patients will experience adnexal torsion, and the vast majority of patients, almost 80%, it's associated with an ovarian or a paraovarian mass. Ultrasound is the first line to evaluate patients with adnexal torsion, and CT and MRI typically reserved for more complicated cases or problem solving because of suggestive findings. What do we see on ultrasound in adnexal torsion? So you will see an ipsilateral enlarged hypoechoic ovary with or without peripheral follicles, and this corresponds with the site of the patient's pain. Because 80% of patients have a lead point, you'll see a mass, either a teratoma or a functional cyst. You can see associated fallopian tube thickening, and then you can see ascites. So this transvaginal ultrasound image shows the right ovary to be massively enlarged. It has a volume of 125 cc's. You also see that it has this approximately 4 centimeter lesion, which has this large echogenic component along one wall. This was actually a dermoid. I'll be discussing the features later. And this was the lesion that predisposed the ovary to torsion. When you put color Doppler on, you see that there's no detectable flow. The ovary also appears more hypoechoic than usual. And this is a portion of the dermoid, again, that's imaged, that we're catching on the color Doppler image. It's good practice to always have the technologist do cine imaging through the Adnexal so that you can evaluate for the whirlpool sign or the twisted pedicle sign. This is also described as corkscrew vessels. So in this example, you can see flow within a normal left ovary. On the right side, which was the side of the patient's spine, the ovary is much more larger and there's no demonstrable flow on color Doppler evaluation. The patient also has a tiny amount of ascites. Now, I want you to remember that the absence of arterial and venous flow in the ovary can actually be a late finding because the ovary has dual supply from the ovarian artery and the uterine artery. And what you might see typically is high resistance arterial flow. What I mean by that is basically you will have very little diastolic flow on the arterial waveform, and you can actually see absent venous flow as well. The important thing to remember that is even if you're able to document flow within the ovary, if the symptomatic ovary is enlarged, you should always continue to maintain a high index of suspicion for ovarian torsion. How about in CT? So on CT, what we're looking for is basically an enlarged edematous displaced ovary. It tends to be more high riding within the pelvis rather than lower down in the pelvis. You'll also see that the uterus is deviated to the affected side. There'll be obliteration of fat planes. You can look for the beak sign or the twisted pedicle sign, and the ovary will enhance less than normally. So on these axial and coronal contrast enhanced images, you can see that the uterus is deviated slightly to the right of midline towards a larger right ovary, which is relatively hypoenhancing. And here, this orange arrow is actually showing you the twisted pedicle sign. I included this example from the literature for adnexal torsion and MRI because I think it really beautifully shows the twisted pedicle sign. Hopefully the cine clip pays, and I want to draw your attention to the arrow in the right adnexal, which actually shows the whirlpool sign or the twisted pedicle sign. So hopefully this is going to work. Here you can see the arrow there showing the twisted pedicle. Okay, let me see if I can play it back slowly a little bit. So basically, this is a massively enlarged right ovary. You'll see that it has a follicular cyst, and then it also has what looks like a hemorrhagic cyst with retractile clot. There's a small amount of ascites. Okay, and this is a smaller left ovary also containing a dominant follicle. And then when I scroll backwards, the arrow is pointing to the twisting of the vascular pedicle or the whirlpool sign. So hopefully you can appreciate that this is the resource information that you can visit if you want to see that again. All right, let's talk about polycystic ovarian syndrome. It affects about 6 to 8% of female patients. Now, to establish a diagnosis of PCOS, there's certain criteria that have to be met by this society. It's called the AE-PCOS. So these include the presence of hyperandrogenism, with clinical and or biochemical markers, ovarian dysfunction, so that includes oligomenorrhea and ovulation with or without polycystic ovaries, and then you have to exclude related disorders that can produce these symptomatology. Perhaps you've heard of Sturm-Levin-Towns syndrome, which is basically a spectrum of hirsutism, obesity, amenorrhea, and bilateral enlarged polycystic ovaries. Let's see what these look like on imaging. So typically you'll see 12 or more follicles. The follicles are greater than 2 to 9 millimeters in size. And when you look at the ovaries on imaging, you'll see that these are predominantly in a peripheral distribution within the ovarian parenchyma. So here you can see this on ultrasound, and this is described as a string of pearls appearance. You'll see increased ovarian volumes, typically more than 10 centimeters. Now, even if one ovary has this appearance, it fulfills the criteria for PCOS. In the past, it used to be thought that echogenic stroma was a criterion. So basically, you'd see increased echogenicity in the central ovarian parenchyma, but that's kind of fallen by the wayside and not used anymore. It's important to remember that almost 30% of patients will have normal ovaries in the setting of PCOS, and the mainstay of diagnosis is really clinical, and it's an elevated LH to FSH ratio. So this is what the ultrasound appearance is like. This is an axial T2 weighted image, which shows enlarged ovaries bilaterally. And again, you can see the string of pearls sign more typically in the left ovary. Now, I want you to remember that this is a very different look than the appearance of theca lutein cysts, which I showed previously. Those ovaries were really, really massively enlarged. I think like one was almost 7.4 centimeters, and the cysts in that scenario were much larger and randomly distributed within the ovarian parenchyma, in contrast to the string of pearls appearance that you see with PCOS. So now moving on to benign adnexal entities. So these are entities that are adjacent to but separate from the ovary. I'll be talking about tubal pathologies, namely hydrosalpinx and pelvic inflammatory disease, and then also briefly touch on paraovarian cysts and peritoneal inclusion cysts. Again, these are all ORADS 2 lesions. So what is a hydrosalping? It's basically a dilated fallopian tube, like in this example here. It usually occurs as a sequela of pelvic inflammatory disease, can also occur due to endometriosis and surgery. And they have a pathognomonic configuration on imaging in that they're kind of tubular or serpiginous with a septated morphology, and that leads us to suggest a diagnosis of a hydrosalpinx. There's a couple of other signs that are described in radiology, predominantly in ultrasound for hydrosalpinx. So one of these is the waist sign, and what it is basically the folding of the distended fallopian tube upon itself causes indentations on diametrically opposite side of the tube. Like in this ultrasound image, the orange arrows are showing you the waist sign within a right hydrosalpinx. This T2 weighted axial MR image through the pelvis again shows a hydrosalpinx with the waist sign delineated by the orange arrows. The other sign that's described is less frequently used, but it's called a beads on a string sign due to incomplete septa. And here you can see the orange arrows pointing to the beads on a string. So waist on a waist sign and beads on a string sign. How about PID or pelvic inflammatory disease? So ultrasound is usually what the clinicians will order first to evaluate patients with suspected PID. CT MRI are reserved for more difficult cases and for problem solving. Imaging can be entirely normal in PID. Sometimes you can see an indistinct uterus or endometrial fluid, like in the example here. You can also see complex pelvic free fluid, like shown in this example here. You can see a thick wall fallopian tube, and then finally you can see a dilated tube containing internal echoes or debris. So on this grayscale ultrasound image, here's the ovary. This is the dilated fallopian tube containing diffuse echoes consistent with the biosalpinx. This color Doppler transvaginal image again shows a dilated fallopian tube, particularly its fimbriated end, and the orange arrow is pointing to a fluid debris level. Again, this is consistent with a biosalpinx. These examples from the literature describe two other findings in pelvic inflammatory disease. The first is called the cogwheel sign, which is basically due to tubal inflammation. And what you see is a thickened fallopian tube. So these infolding projections have basically been likened to a cogwheel appearance. The second thing that you can see is a tubo-ovarian abscess or complex. So this example shows a complex multiloculated cystic mass within the right adnexa. When you have a tubo-ovarian abscess, on ultrasound it becomes very difficult to delineate the ovary separately from the adjacent inflamed adnexa. If you put color Doppler on, you will see flow within the solid tissues separating the cystic components, and then you'll see ascites, which typically is complex and contains low-level internal echoes. These are examples of PID from the literature. Here on this contrast-enhanced axial CT, here's the uterus. You see this multiseptated a complex mass within the left adnexa with a small amount of anterior free fluid as well. The patient went on to MRI. So here's the uterus on this coronal T2 weighted image. There's a multiloculated complex mass within the left adnexa. This medial component is T2 hyperintense. The lateral component is a little bit more complex with hypointense components. You can see that it also has this tubular or serpiginous morphology. So this was a tubo-ovarian abscess. And again, the patient has a small amount of ascites. The same patient, sagittal post-contrast, fat-suppressed T1 weighted image, you'll see enhancement at the periphery of the lesion as well as between the complex cystic components. So these are all features of tubo-ovarian abscess on MRI and CT. Now, I will say that you have to remember that there's a considerable overlap between tubo-ovarian abscess in the setting of PID and cystic ovarian neoplasms on imaging. You might see more inflammatory stranding with PID and TOAs, but really sometimes the imaging is indistinguishable. So history and clinical findings are really crucial. If the patient has symptoms of fever, vaginal discharge, and pain, you're going to more likely suggest TOA, but irrespective, you want to make sure that the patient gets follow-up imaging after institution of appropriate therapy to make sure that the adnexal findings resolve. Moving on to para-ovarian or paratubal cysts, these account for 10 to 20% of adnexal masses, and they arise in the broad ligament from mesothelial and paramesonephric remnants. They can occur in women of any age, and they can be any size. On imaging, these are simple unilocular adnexal cysts. A good advantage of ultrasound is that when you do TV imaging, you can actually use probe pressure to separate the paraovarian cyst from the ovary and confirm a diagnosis of a paraovarian cyst because it moves independently. On this axial T2 weighted image, you can see the uterus. Here's a normal left ovary, and then this is T2 hyperintense lesion was a left adnexal paraovarian cyst. The final category in benign entities is peritoneal inclusion cysts. This is loculated peritoneal fluid within adhesions, and it typically occurs as a sequela of pelvic surgery, endometriosis, or pelvic inflammatory disease. It occurs in both pre- and postmenopausal patients. And in contrast to cystic ovarian neoplasms, which are typically mass-forming, peritoneal inclusion cysts are kind of passive, and they conform to the peritoneal cavity. And I'll show you examples of the same. So this is peritoneal. This is an example of a peritoneal inclusion cyst on imaging. It's a septated cystic peritoneal lesion, which can either surround the ovary or it displaces the ovary. You may or may not see flow in the septations. So here on these grayscale transabdominal images, you can see that there's a septated cystic peritoneal lesion, and you can see that the left ovary is basically suspended within this septated fluid. Here on this axial contrast enhanced CT through the pelvis, here's the uterus, right ovary, left ovary, and again, you can see septated ascites within the pelvis. You can see the internal architecture much better on this axial T2 weighted image. Here's the uterus, left ovary, right ovary. Here's the septated cystic peritoneal lesion, and the ovaries are kind of suspended within this lesion. This is what is called a spider in a web appearance, if you can imagine that. Like this is the spider suspended within the web. All right, moving now to the categories of ovarian neoplasms. This article from Radiographics 2021 is actually an excellent resource for the discussion of ovarian neoplasms if you want to visit it later on. So there's four main categories of ovarian neoplasms. The most common is epithelial cell neoplasms, followed by germ cell neoplasms. Then you have sex cord and stromal tumors. And finally, you have ovarian metastases. We'll first talk about ovarian epithelial neoplasms, which are the most common category. They account for 50% of ovarian neoplasms. 60% of these lesions are benign, 30% are malignant, and 10% are borderline or low malignant potential, which are called LMP. Now, how do we categorize borderline or malignant neoplasms on imaging? We're basically looking for these features. We're looking for mural nodules. We're looking for enhancing components. And these enhancing solid components have to be non-fatty and non-fibrous, so basically excluding dermoids and fibromas. And also you'll see thickened enhancing walls and septa, which are typically more than 3 millimeters. This is the WHO classification of ovarian epithelial neoplasm. So the 4 categories that I'll be discussing are serous, mucinous, endometrioid, and clear cell. I will not be discussing Brenner or seromucinous and undifferentiated cancers. How about the role of CA125? Now, CA125 is abnormally elevated in 85% of patients with ovarian cancer, but I want you to note that it can be false negative in half of patients with stage 1 disease. Almost 1/3 of patients with mucinous cancers can also have a false negative CA125. It can also be positive in benign ovarian tumors and in endometriosis. So really in clinical practice, the role of CA125 is in the surveillance of patients with known ovarian cancer, either to make sure that they continue to be in remission or to detect recurrence. Let's first talk about serous epithelial cell neoplasms. Now, these are typically bilateral lesions. 63% are benign, 30% are malignant, and 7% are low malignant potential. They're the category that have the strongest association with CA125. Remember, I said up to 30% of mucinous tumors will have a false negative CA125. There's 4 major subtypes, and these subtypes are basically characterized on pathology based on these features. But 4 subtypes are benign, borderline, low-grade serous carcinoma, also called LGSC, and then high-grade serous carcinoma, also called HGSC. So let's look at the imaging characteristics of the 4 subtypes. A benign serous cystadenoma is typically a unilocular thin wall cyst. It may have thin septa. On this transvaginal ultrasound image, you see a fairly large, basically simple cyst. This contrast enhanced axial CT image shows a large, simple appearing cyst. On an axial an axial T2-weighted MR image, you see a fairly large cystic lesion, which is malilopulated, and it also has thin incomplete septations. This was a pathologically proven benign serous cystadenoma. How do we differentiate serous borderline cystadenoma and low-grade serous carcinomas? So these are more complex appearing lesions compared to the cystadenoma I showed previously. They're multilocular and they have variable solid components. What I mean by the solid components is that they have enhancing papillary soft tissue projections or mural nodules. Surface nodules are kind of uncommon. The low-grade variant, or LGSC, frequently also has pseudomatous calcifications, and these are typically coarse calcifications. So here on this sagittal T2-weighted image, you can see this T2 hyperintense lesion. The orange arrows are showing small mural nodules abutting its wall. On this axial fat-suppressed post-contrast image, you'll see that the nodules actually enhance. And this non-contrast axial pelvic CT image shows the coarse calcifications that are typical of LGSC. How do we differentiate high-grade serous carcinoma, or HGSC, which is the most common subtype of malignant ovarian carcinoma? Now, it's now believed that HGSC actually arises from the distal fimbriated end of the fallopian tube. And perhaps you've heard this terminology. They're called stick lesions. And stick is basically an acronym for serous tubal intraepithelial carcinoma. In contrast to the images I showed before, these are cystic adnexal masses, which have a large solid component. And infrequently, these lesions have pseudomatous calcifications, like in the example of LGSC that I showed previously. So this example from our practice, these are axial, sagittal, and coronal contrast enhanced images through the pelvis. You'll see this large mass, which has a pretty large solid enhancing component here that you can see on these images. It's pretty large, extends almost to the level of the umbilicus, and this was a pathologically proven high-grade serous carcinoma. Now, some of these patients can actually present with metastatic disease initially, and this can manifest as large volume ascites, peritoneal nodularity or carcinomatosis, and lymphadenopathy. And these axial contrast enhanced images through the pelvis, you actually see bilateral high-grade serous ovarian carcinomas. The patient also has ascites. When you look at the upper abdomen, you can see that in addition to the ascites, there's some peritoneal soft tissue nodularity consistent with carcinomatosis. At the level of the mid-abdomen, you see a tiny amount of ascites, and then you can nicely see denoted by the orange arrows, the omental soft tissue nodularity, which is called omentum caking or carcinomatosis. This axial fat-suppressed T2-weighted image shows a large adnexal mass. This orange arrow is actually pointing to a malignant lymph node in the left external iliac chain. The same patient, this is a post-contrast fat-suppressed sagittal image, which shows a large enhancing soft tissue mass, and the orange star is actually showing a soft tissue within the anterior cul-de-sac that's abutting the urinary bladder that was consistent with carcinomatosis. So much, much more worrisome a lesion than the examples that I showed previously. The next category of epithelial cell neoplasms is the mucinous category. So this actually has three subtypes, and these are benign mucinous cystadenoma, borderline mucinous neoplasm, and mucinous cystadenocarcinoma. How can we try to differentiate these lesions from the serous variety that I showed previously? Now, these are typically unilateral. Remember, serous cancers can be bilateral. They're confined to the ovary, and typically they're much larger than serous neoplasms. What's described is this classic appearance of a stained glass pattern on MRI. And this is because the differing mucin viscosities within this lesion cause a differing appearance to the intracystic content. So this is nicely shown in this example. This is a T2 axial image through the pelvis. Here's the uterus, and you can see this large multi-loculated cystic adnexal lesion. You can see how this components of this lesion are more T2 hypointense, producing this classic stained glass morphology for mucinous neoplasms. Let's talk a little bit about the three main subtypes. Mucinous cystadenoma can be associated in 10% of cases with mature teratoma or Brenner tumor. And if sometimes these lesions can have abundant fibrous stroma, then they're called mucinous cystadenofibromas. So here's an example from our practice. These are axial T2-weighted images showing a large T2 hyperintense mass within the adnexa. You can see that it has thin septations, some of which are incomplete. On this sagittal fat-suppressed T2-weighted images, you can see again a really large T2 hyperintense lesion with thin septations. The axial post-contrast fat-suppressed images demonstrate no internal enhancement, and this patient was taken to surgery and it came back as a mucinous cystadenoma. This example actually shows a large multiloculated cystic adnexal mass. Here's the uterus, which is actually displaced anteriorly, and it also has a peripheral solid enhancing component. This turned out to be a coexistent Brenner tumor on pathology. What about borderline mucinous neoplasms? What do they look like on imaging? So they're kind of typically more complex. You'll see increasing internal loculations. You can see high T1 or low T2 intensity within the intracystic components, and then increasing septal thickness and mural nodularity more than 5 millimeters. So this axial contrast enhanced CT image through the pelvis shows a large cystic adnexal mass. This component actually has a multilocular configuration, and you can see some enhancing mural nodularity. You'll appreciate the same thing on this transabdominal ultrasound image, which shows a multiloculated cystic mass, and the orange arrow is actually showing a mural nodule. And this was again pathologically confirmed borderline mucinous neoplasm. The last variety is mucinous cyst adenocarcinoma. Again, this is a multilocular lesion. And like I said before, these locules have varying signal intensity, attenuation, and echogenicity at MRI, CT, and ultrasound, respectively. In contrast to the serous lesions, which I showed previously, papillary projections are uncommon, and calcifications occur less frequently in about 1/3 of patients. When they do occur, they tend to be more linear and not a coarse and peripheral, like the example of LGSC I showed previously. Now, rupture of these lesions can lead to a condition called pseudomyxoma peritoni, but I want you to remember that pseudomyxoma peritoni actually is more common with rupture or metastases from appendiceal mucinous cancers and not so much from mucinous cancers in the ovary. So here are axial contrast enhanced images through the pelvis. Here you can see the uterus deviated anteriorly. The cystic structure within the right hemipelvis is actually the urinary bladder because it fills with contrast on delayed imaging. And within the posterior cul-de-sac, you see this large complex multiloculated mass. Perhaps you can appreciate its multiloculated nature and multiple thin septations on CT. This is another example of pseudomyxoma peritoni. You see this classic low-density septated ascites, which is scalloping the liver edge, and this appearance is characteristic for pseudomyxoma peritoni, again, more common with appendiceal mucinous cancers. Here's an example from our practice, a 72-year-old patient who presented with pelvic pain. These are transabdominal, sagittal, and transverse images. Here's the uterus with a tiny amount of endometrial fluid. You'll see in the posterior cul-de-sac that there's this pretty large multiseptated or multiloculated cystic lesion as well as small ascites. On transvaginal imaging, you'll see that this lesion measures more than 15 centimeters in length. And in terms of its internal architecture, it has multiple cystic locules, which are variable in echogenicity. Some of these are more anechoic. Some contain low-level internal echoes. So again, this corresponds with a stained glass appearance on MRI. And this patient had a mucinous cyst adenocarcinoma. Another example from our practice, this time within the right adnexal, a fairly large, almost 15 centimeter mixed solid and cystic mass. When you put color Doppler on, there's internal vascularity within these solid pairing components. The patient goes on to have ACT, and again, you can see this pretty large multiloculated cystic mass with variable CT attenuation. It extends almost to the level of the umbilicus, and there's also a small amount of pelvic ascites, but otherwise no significant carcinomatosis, and this patient had a pathologically proven mucinous cyst adenocarcinoma. I'll talk briefly about the less common variants, endometrioid carcinoma and clear cell carcinoma. These are almost always invasive and malignant, but usually low grade. They typically present in females who are in the 5th decade of life. Both have a strong association with endometriosis. So 39% of patients with endometrioid cancer and 41% of patients with clear cell cancer have coexistent endometriosis. Both endometrioid cancer and clear cell cancer are also associated with Lynch syndrome and synchronous endometrial cancer. And what we look for in imaging, we're basically looking for changes in a classic endometrioma. So when we look on ultrasound or MRI, what we'll see is a vascularized or an enhancing mural nodule in a pre-existing endometrioma. Here's an example. This coronal T2 weighted image shows a large, complex, solid and cystic mass within the left adnexa, as well as a small amount of pelvic ascites. The larger orange arrow is pointing to a synchronous endometrial cancer. Same patient, these are fat suppressed T1 saturated imaging showing a large, complex, and solid and cystic mass within the left adnexal, and this was pathologically proven endometrioid carcinoma with asynchronous endometrial cancer. Another example, this time this patient has a left adnexal mass on transabdominal imaging. This is the uterus, the urinary bladder. It shows arterial flow on color Doppler evaluation. The patient had a MRI to better evaluate this. You'll see on axial T2 weighted images, there's a predominantly solid mass within the left adnexal. It has smaller cystic components. On the axial post-contrast fat-suppressed images, there's internal enhancement. Patient went to surgery, and this turned out to be an endometrioid carcinoma. Clear cell carcinomas are important in that they tend to occur more frequently in East Asian women. In 27% of patients, there can actually be thromboembolic events. So the patients can actually present with DVTs and PEs. They can also have paraneoplastic hypocalcemia. And from the clinical standpoint for the clinicians, these are the cancers that are actually less sensitive to platinum-based chemotherapeutic agents in the later stage. So I didn't have an example of clear cell carcinoma. So this is an example from the literature. These are initial images, anaxial T2 through the pelvis showing the uterus, and then this left adnexal lesion with characteristic shading on T2. T1 hyperintense on fat sat post-contrast images. So this was consistent with an endometrioma. Now, this patient was followed, and with time, you'll see that the lesion actually significantly grows in size. It also changes its signal intensity. So you can see that it loses its T2 shading, and it develops this large solid component along the medial wall. It also loses T1 hyperintensity and becomes more T1 hypointense on a T1 weighted image. And this diffusion weighted imaging shows increased uptake within the solid component. So this was a pathologically proven clear cell carcinoma. I'll talk about the germ cell tumors, teratoma, mainly mature, immature, and monodermal subtypes, and I will not be discussing these less frequent variants. So mature teratomas are dermoids. They contain 2 of the 3 germ cell layers. They are the most common germ cell tumor, and they can be bilateral in 10 to 15% of patients. These lesions are typically asymptomatic and detected incidentally, but if large, they can cause pain, and they can also serve as a lead point for adnexal torsion. Rare cases, they can rupture and produce a chemical peritonitis. The incidence of malignant transformation is really, really low, less than 2%. When it does occur, it's usually squamous cell carcinoma or papillary thyroid cancer. And perhaps you've heard of this entity that can be seen occasionally with dermoids. It's called NMDA receptor limbic encephalitis. So let's look at the many phases of dermoid on ultrasound. The first is a dermoid plaque. This is the most common appearance on ultrasound. And what you'll see is basically an echogenic component to the lesion that shadows. This is called the dermoid plaque or the Rokitansky-Ashkoff nodule, and it's basically due to the teeth, fat, bone, or hair within the lesion. Okay. The second most common manifestation is what is called the tip of the iceberg sign. So on this transvaginal imaging, you can see a little bit of a normal appearing right ovary, but the majority of the right ovary is actually occupied by this lesion with intense shadowing that's echogenic. This is called the tip of the iceberg sign, and it's usually due to the presence of sebum or hair within the lesion. Less commonly, dermoids can manifest with a dot and dash pattern, which you can see here on this image. This is due to the presence of hair. And even less commonly, they can present with a fat fluid level. So here's the right ovary. You can see an echogenic layering component, which basically corresponds with a fat fluid level. Let's look at CT. These non-contrast axial CT images show typical appearances of a dermoid, large fat component, and then the soft tissue component corresponding with the dermoid plug. This lesion has multiple components of fat, soft tissue, calcium, as well as a fat fluid level. This patient had a dermoid that ruptured, so you can see fat in the adnexal side of the dermoid, as well as anterior to the left hepatic lobe. She also has ascites, and there's associated peritoneal enhancement within the flanks as well as in the posterior cul-de-sac. So she actually had achemical peritonitis. How about MRI? These are two examples. Here's an axial T2 weighted image showing a T2 hyperintense lesion with small hypointense components. These are in and out of phase images showing loss of a signal on out of phase imaging consistent with intralesional fat and no internal enhancement. The second example shows a normal left ovary and the uterus, a T2 hyperintense lesion within the right adnexa. Here's the in and the out of phase imaging showing a loss of signal on the out of phase, as well as a fat fluid level and a dermoid plug. And again, on axial post-contrast fat suppressed imaging, there's no internal enhancement within these lesions, which is typical of dermoids. Now, immature teratomas are the most common malignant germ cell tumor in the US. They tend to affect younger females, and they can be really, really large. So median size is 18 centimeters. And the way you differentiate them from mature teratomas is that these lesions are more heterogeneous, and they contain more solid enhancing tissue and less amounts of fat and calcium. Let's look at an example from our practice. So these are axial coronal and sagittal CT images of the pelvis. You'll see this really large adnexal mass abutting the uterine fundus. It extends almost above the level of the umbilicus. You'll see that it predominantly contains soft tissue and less amounts of fat and calcium. The patient also has ascites. You can see a little bit of peritoneal enhancement in the posterior cul-de-sac. So this patient had a malignant teratoma that was confirmed on pathology. This example shows a metastatic teratoma. So there's metastatic disease within the pelvis, and you'll also see these capsular implants involving the liver and spleen, which show evidence of fat, calcification, and soft tissue. And this is basically metastatic disease from a malignant teratoma. I just included monodermal teratoma. It's a really rare, and the predominant cell type is actually thyroid tissue, but it has some characteristic findings on imaging, so I want to include that. The thyroid tissue is actually called stroma ovari. Now, in ultrasound, what you can see when you do see it is a solid echogenic component, which is actually shows a pretty prominent internal vascularity. Remember, I told you that the other echogenic tissue in the ovaries is a dermoid, which doesn't show vascular flow. So this is called the stroma pearl. And on CT, because of the high iodine content, on non-contrast images, these lesions are actually high in density. When you give contrast, they kind of show avid enhancement. Here's an example of stroma ovari from the literature. So you can see this echogenic component within the cystic lesion, which is really, really vascular on color Doppler ultrasound. On these non-contrast images, you can see a fairly large adnexal mass that has intrinsic high density in CT, and this was proven to be stroma ovari on pathology. The next variant I'll talk about is sex cord-stromal tumors. They're about 5 to 8% of ovarian neoplasms. They can be either pure sex cord, pure stromal, or mixed type. The sex cord cells are the granulosa and Sertoli cells. Stromal cells are thicker cells, fibroblasts, and Leydig cells. Now, these are hormonally active lesions, so they tend to present earlier because they can secrete androgens, estrogens, and corticosteroids. They're typically confined to the ovary, and except for granulosa cell tumors, they're predominantly solid. Now, the vast majority of granulosa cell tumors occur in adults, about 95% of patients, and because they secrete estrogen, they present with abnormal uterine bleeding. So the patients are at increased risk for endometrial hyperplasia or cancer. A small subset occurs in prepubertal females manifesting as precocious puberty, and they can also be seen with enchondromatosis, mainly Maffucci syndrome and Ollier syndrome. Now, these are typically large, multilocular, solid, and cystic masses with areas of hemorrhage, and the appearance is really typical is very similar to serous epithelial neoplasms. But the way you can differentiate them is that these are typically unilateral. They do not show papillary projections, and they typically don't cause peritoneal seeding. On ultrasound and MRI, the characteristic appearance is described is a Swiss cheese appearance, and I'll show an example of that. This is an example from our practice, a patient with a large mixed solid and cystic mass within the left adnexal on ultrasound. Here's contrast-enhanced axial and coronal CT imaging, again showing a predominantly solid mass within the left adnexal, a tiny amount of ascites, and this patient had a proven granulosa cell tumor. This is an example from the literature that I alluded to before, which showing the characteristic Swiss cheese pattern. This is a post-contrast FAT-SAT T1 weighted this is the post-contrast FAT-SAT T1 weighted image. This is the T2 FAT-SAT image. Here's the uterus, and here you can see this characteristic Swiss cheese or sponge-like appearance of granulosa cell tumors. Talking now about fibromas, thecomas, and fibrothecomas. Bilateral ovarian fibromas can occur with Golden-Coates or basal cell nevus syndrome. You've probably heard about Meek syndrome, which is a right pleural effusion with ascites and an ovarian fibroma. Now, the thecoma component of these lesions produces estrogen, so they can be hormonally active. On ultrasound, you typically see a hypoechoic mass with edge artifact, which basically is due to a curvilinear reflector, and you'll see posterior acoustic shadowing. So what I teach my residents is basically these look like fibroids within the adnexal. Little or no flow on color Doppler, and the main differential is a pedunculated myoma. The way you can differentiate these is the bridging vascular sign. So for pedunculated myoma, you'll see vascular contiguity from the uterus to the myoma. On MRI, the lesion shows characteristics typical of fibrous tissue, so T1 and T2 hypointense. If large, they can be hyperintense due to edema and cystic degeneration. And then, like all fibrous tissue, they show delayed enhancement. So here's an example. This is a transabdominal ultrasound. Here's the uterus. You can see a complex adnexal mass. These are T2 weighted sagittal and axial imaging, again showing the uterus with a myoma, and then this large, fairly complex appearing lesion within the posterior cul-de-sac. No loss of signal on in and out phase imaging, so no intralesional fat, no early enhancement on the early phase, but then delayed enhancement on the sagittal fat suppressed post-contrast T1 image, so all characteristics of fibrous tissue, and this was a fibrothecoma. This is an example of a left ovarian fibroma on ultrasound. You can see that the lesion is hypoechoic and markedly shadowing. It's also showing the edge artifact. The patient has a tiny amount of ascites. And then this axial and coronal T2 weighted image, you can see that the lesion is uniformly T2 hypointense, all characteristics consistent with a fibroma. And this lesion has just been followed on ultrasound. I'll finally wrap up talking about ovarian metastases. So ovarian metastases can occur from multiple primaries, GI tumors like colon, appendix, stomach, and pancreas. They can also occur due to breast cancer, lung cancer, or even from the contralateral ovary. Now, ovarian metastases are typically bilateral. Gastric and breast metastases tend to produce solid ovarian masses, whereas appendiceal, colorectal, and pancreatic or biliary tumors tend to produce cystic ovarian metastases. Now, we often use Krugenberg tumors in the context of bilateral ovarian metastases, but strictly speaking, the Krugenberg tumor is really a pathological diagnosis. So the tumor has to have at least 10% of mucin-filled signet ring cells on pathology to qualify as a Krugenberg tumor. And let's look at some examples. This is coronal CT image post-contrast. You can see this is the uterus. These are large bilateral cystic ovarian lesions. Incidentally, the patient also had this tubular low-density structure that was contiguous with the appendix. So when the patient went to surgery, this turned out to be an appendiceal mucinous cancer with bilateral ovarian metastases. And I think this is my final example. A patient presented with pelvic pain. On ultrasound, you can see that she has heterogeneous, solid appearing ovarian masses, both with internal vascularity, also a small amount of ascites. She subsequently underwent a CT to evaluate for primary. So here through the pelvis, you can see the bilateral solid ovarian masses, some pelvic ascites. Here's the uterus containing an IUD. And the same patient, when you image through the upper abdomen, you can see that she has abnormal gastric wall thickening. She has nodal disease in the perigastric region, some nodes in the gastrohepatic ligament space as well. A little bit below, you can see that there's some infiltration of the omental fat with some soft tissue nodularity. So this was a patient with gastric cancer presenting with bilateral solid ovarian metastases. And that concludes my whirlwind tour of imaging of adnexal masses. I hope that I've been able to share some insights that you find useful, and I'm happy to take any questions.
Thank you
Thank you
very
so much,
much.
Dr. Shabnam. That was an amazing lecture.
Yeah. Thank you very much.
It's my
I can
pleasure.
see questions. Maybe I can go over them.
Sure.
First two or three. The first question was regarding PCOS, about the number of the follicles. In this presentation, it was said more than 12 follicles. And she asked, is it not 19, or maybe what criteria was used? I believe there are also there's been a transition on the diagnostic criteria. And then the second question was Mucinous cystadenoma. Can it present with pseudomyxoma peritonei?
So, in terms of the first question, I personally, in my practice, I don't pay attention to the number of follicles as much because there's a lot of variability in the literature. I said 12, and the question was 19. I look more typically for the distribution of the follicles. So what I want to see is multiple tiny follicles, which are kind of uniformly sized, and I want to see them predominantly at the periphery of the ovary, producing that string impulse sign to call them PCOS. And I really use it in the context if a clinician is suspecting PCOS based on the lab data, so if there's an elevated LH, FSH, because I've seen a lot of younger looking ovaries that can almost have this polycystic appearance, but I don't necessarily suggest it unless I see that specific clinical scenario in that context. So that's my personal experience. In terms of the pseudomyxoma peritonei, so for if you do have a mucinous cancer that causes pseudomyxoma peritonei, it's going to be the mucinous cyst adenocarcinoma, not the cystadenoma. Okay, because the cystadenoma is basically a benign lesion and it's not going to present with a pseudomyxoma peritonei. And really, most of the cases of pseudomyxoma peritonei in the literature are actually due to appendiceal mucinous cystadenocarcinoma. It's thought that ovarian mucinous cystadenocarcinoma less likely ruptures and causes a PMP compared to appendiceal neoplasms. I see a question here about peritoneal inclusion cysts from septated ascites. So I think the big thing here is the clinical history. So you want to see if the patient has had a history of pelvic surgery predominantly to raise the diagnosis of peritoneal inclusion cysts. And the other thing is the typical appearance of the ovaries, that they kind of look suspended within the septated peritoneal fluid. When you see septated ascites, you don't typically get that appearance of a lesion that conforms to the cavity with the ovaries suspended within the septation. So loculated ascites basically tends to be randomly distributed like components within the pelvis. They don't like surround the uterus and the ovaries and produce that spiderweb appearance. Hopefully that makes sense.
Thank you, Dr. Shabnam.
There's
I think,
something about a
yeah.
cutoff point for CA125. I'm actually I would have to look that up, but I think probably one of the GYN oncologists would be like a better person to would be more qualified to answer that. So I would have to look that up.
Okay, another question was, should the ovaries be enlarged to diagnose polycystic ovaries?
Not
And
necessarily,
sometimes you see features of PCOS. Yeah.
so
Yeah, I
not
think he also
not
answered in.
necessarily. Yeah, not necessarily. So like I said, in my practice, I do see a lot of younger patients with, their ovaries just tend to be plump when they're more like in the earlier part of their menstrual age. So I don't necessarily think of polycystic ovaries unless it's presented as something that the clinicians are concerning. If I see the characteristic, if one or both ovaries is pretty large and I see the characteristic string and pearls, I will say in my report that this is an appearance which has been seen in the setting of polycystic ovarian syndrome, but it's really something that they have to make sure meets all the criteria for PCOS based on the criteria I showed before. So the patient would have to have an elevated LH-FSH ratio and then have all the other clinical manifestations for them to be called PCOS. Because remember, in 30% of PCOS, the ovaries can be normal.
And the last question was, can we have a quick recap on the differences
Sorry, I
of
didn't hear that.
Mucinous
I think
and
there is an
Serous
issue
and
with
Mucinous
connection.
adenocarcinoma?
The question was, can we have a quick recap on the differences of the imaging features of serous and mucinous ovarian cystadenocarcinoma?
Okay, so basically, the quick recap for serous and mucinous cystadenocarcinomas are serous cystadenocarcinomas, so more typically the high-grade serous cystadenocarcinomas. They tend to be more frequently bilateral than mucinous lesions, okay? So frequently at the time when you diagnose them, the patients will have things like extraovarian metastases. So you'll see ascites, you'll see peritoneal seeding, you'll see metastatic nodal disease. All of those features are less common with mucinous varieties. In terms of the mass itself, a high-grade serous adenocarcinoma is basically a mixed solid and cystic mass with a large solid enhancing component, okay? When you contrast that with mucinous cystadenocarcinomas, they're even larger than serous cystadenocarcinomas. They're more typically unilateral, so they don't really occur bilaterally, okay? And the typical imaging feature of mucinous cystadenocarcinoma, like in the examples I showed you, is a multi-loculated cystic lesion that has those variable echogenicities and intensities on CT, ultrasound, and MRI because of the differing mucin content. So it basically has that stained glass appearance, and you're not going to see a substantial solid enhancing component like you did in serous cystadenocarcinomas. So hopefully that answers it.
Thank you. I do not see any more questions.
And someone was asking on, someone was just asking on getting this presentation initially. I'm not sure if it was a
They're
I think
asking
maybe
if
it's
they can get
recorded.
or
Perhaps this is recorded.
video
Yes,
of
this is
this
recorded,
today's
and you can find this
presentation.
in our YouTube channel after a week. So, yeah. I think someone was asking if they can get the presentation PDF or something like that. But I think
Uh, I can
Yes,
try.
I
Honestly,
believe.
in the past, the issue with a lot of these presentations is because they have so much of imaging. It's kind of hard to actually convert them, but I can certainly try. Yes.
Yeah. I think you can find the lecture after a few days in the YouTube channel, I think. Yeah. Thank you so much, Dr. Shabnam. That was an awesome lecture.
Uh, Thank you so much for inviting me. It's truly
Yeah,
been a pleasure and an honor for me to be speaking to you. And I hope I've been able to share some information that you guys will find useful in your practice. So thank you again.
Pleasure is ours. Thank you so much, Dr. Erin.
Thank you.
Yeah.
Bye-bye.
Have a nice day, everyone. Bye bye.
You
bye.
as well. Bye-bye.
Thank you.